You're listening to Boomers Today with your host, Frank Sampson.
Oh, welcome to Boomers Today. I'm your host, Frank Sampson. Of course, each week we bring you important and very useful information on issues facing baby boomers, their parents, and other loved ones. And I just, as I do on every show, I thank all of you. And I thank all of you because our listeners are growing each and every day. And it's because of you. Many of you are sharing our podcasts, the particular shows, or the actual podcast station itself with friends and family, and I can't thank you enough. So many of you are listening to the show on Apple Podcasts, Google Podcasts, Spreaker, Stitcher, iHeartRadio, many of the podcast stations. So thank you so much for doing that and for sharing the information with friends and family. And I know why you do, because we have great guests. We have wonderful guests, provide tremendous education, and we're not going to disappoint you today. We have with us Dr. Michael Grandner, who is Director of Sleep and Health Research Program at the University of Arizona, Associate Professor of Psychiatry and Medicine in the School of Medicine, Associate Professor of Psychology in the School of Sciences, Associate Professor of Nutritional Sciences at the College of Agriculture and Life Sciences, and Associate Professor of Clinical Translational Science. He is also director of the Arizona Behavioral Sleep Medicine Clinic at the Banner University Medical Center in Tucson, which oversees the diagnosis and treatment of sleep disorders using non-medication approaches. So Dr. Grandner, thank you so much for joining us on Boomers Today. I really appreciate it.
Yeah, no, thanks for having me. This is a really important topic, and I'm happy to talk about it.
Great. It is an important one. And as I mentioned to you before, I'm all ears here. I want to listen to all of this. I know too many people who have sleep issues and they immediately go to medication, some sort of medication for it. And we're going to talk about maybe non-medical ways to help. So why is sleep so important? And I guess I'm asking that question because, sometimes people brag and go, yeah, I just need 4 or 5 hours of sleep and I'm good. I'm great. So tell me about is that just a fallacy, or what are your thoughts there?
There are people out there who are getting 4 to 5 hours of sleep and maybe they're doing fine, but sleep is foundational to our biology. We don't sleep because we enjoy it. We don't sleep because it's something we really like. We sleep for the same reason we breathe, because we're built to, and we're required to. The difference is that no one says things like, drinking clear water as opposed to brown, dirty water. That's, that's a luxury for people with too much free time on their hands. Who's got time to drink unpolluted water? What a luxury that would be. Instead, what we have is a society that I think the issue is we see sleep as an unproductive use of time. And there's nothing more un-American than an unproductive use of time. So what we get these social pressures to devalue sleep because we see it as a sort of passive state of rest, and it's a time when you're not getting other stuff done. So we sort of devalue it, or we see it as a badge of honor when we're not able to sleep, and or that we're not sleeping because we don't give ourselves the time. But the truth is, that's like saying, well, I who has time to get all the nutrients they need for their body to function properly? I mean, who's got time for vitamins and minerals? Like, I don't got time for that. And that's sort of what it sounds like to me when I hear people say, I don't really have time to get enough sleep. If people are devaluing it that way, or like, I'll be fine, I'll manage through. And it's sort of like, yeah, I mean, maybe you'll be fine. Maybe you'll be fine if you're a little, vitamin B2 deficient, or you might get some brain damage. Like, who knows? It's probably better to get what your body needs, and you'll live longer, healthier, happier that way. I mean, we know that when you follow people who get 6 hours or less of sleep on average, and you follow them for years or decades, they are more than 50% more likely to become obese because they will gain weight
Wow.
faster, they'll have
Wow.
trouble losing weight, they will crave more unhealthy food, etc. They're also more than 20% more likely to develop high blood pressure if they didn't have it before. They are more than 30% more likely to develop type 2 diabetes. They are more likely to get sick. You catch more colds, more ear infections, and more flus if you're not sleeping. You stay sick longer. Vaccines work less well. You recover slower. The immune system is just totally tied in with sleep and recovery. Every hormone system in the body, testosterone, estrogen, all of these are very closely tied to sleep-wake regulation. You want to lower someone's testosterone? Sleep deprive them. That will systematically lower their testosterone across 24 hours. But all of these systems, like sleep is fundamental to our body working. And when we're not giving our body the sleep that it wants, I mean, you go a night or two without sleep, you're not going to like fall down dead. Just the same thing as you have a few days in a row where you eat nothing but cheeseburgers and pizza, you're not going to get diabetes and a heart attack and a stroke right away. It's just when you have healthier patterns that give your body the raw materials it needs to function as optimally as possible, then you set yourself up for success incrementally better. It doesn't mean that everyone has to sleep perfectly to be happy and healthy. It just means that think of getting healthy sleep just like getting healthy physical activity and healthy diet, where it doesn't have to be perfect, but if you orient yourself towards more of a health mindset, it'll set yourself up for more success. And especially as people get older, because it's one thing when you're 20, but it's another thing when you're 60.
Well, that was leading to my next question. What you just said is age. I mean, when you're talking that it's people need to get sleep, does that matter if you're 20, 40, 60, 80? Is that across the board, or as you get older, you need more sleep, or vice versa? Talk to me
There's
about
an
that.
interesting paradox with sleep and aging. And the paradox is this: as you get older, the sleep does fundamentally change. Most notably, you wake up more during the night. Sleep becomes shallower. You feel less rested in the morning. You're more likely to wake up early and have a hard time getting back to sleep. You're more likely to fall asleep on the earlier side compared to when you were 20. You'll wake up more during the night, spend more time awake during the night. It might take you on average longer to fall asleep during the night. But interestingly, and sleep still has all the effects that it would have. So not getting that good sleep still is problematic. However, as people get older, they also become more resilient to losing sleep. Do they need less? That's a tricky question. I don't know that they need less, but they definitely become, on average, more resilient. What that means is, does a couple of nights of sleep disruption, does that actually impair functioning? A 20-year-old will be way more impaired cognitively and mentally and physically due to sleep deprivation compared to a well-rested night than an older person would be. Older people, maybe they're not quite as strong and fast and sharp as they were when they were 20, but they're a little more resilient, where their performance is going to be decreased less to a lesser percentage. Also, if you look at the correlation that I was just talking about between lack of sleep and all these outcomes, and that's just sleep amount. We haven't talked about insomnia and sleep apnea and other common sleep disorders that we could talk about in a little bit, especially sleep apnea and insomnia, because they increase as people get older. But if you look at hours of sleep and relationships with health outcomes, it looks like those correlations, they still exist in older people, but they're weaker. So for example, if you're 20 and you're getting 5-6 hours of sleep, the degree to which that's going to contribute to everything from smoking to obesity to high blood pressure and diabetes, it's actually doing more damage to a 20-year-old than it is to a 60 or 70-year-old.
Interesting.
Because these are accumulated issues. So if you're 20 and you're spending the next 20 years not getting great sleep versus when you're 70 and spending the next 20 years not getting great sleep, by the 20 years later when you're 40, you shouldn't have so many negative other things going on. But by the time you're 90, the contribution of sleep, that you're probably having other issues going on, that sleep is just one of other things at that point. So it's the relative contribution's a little different.
So this might be, I'm sure you're going to start out the answer to my next question with "it depends."
Well, because I'm an academic and everything, I have to qualify.
It depends. But what's the right amount of sleep?
So for most people, when we look at the population level and we track tens to hundreds of thousands of people at a time, the people who say, on average, I get about 7 hours, live the longest, stay the healthiest, have the best mood, they recover the fastest, get sick the least, etc. Have the fewest strokes, have the fewest heart attacks. The people who say, on average, I get about 7 hours. 8 is not really that different from 7. 7 might be slightly better than 8. 8 might be slightly better at some things than 7. 7 to 8 is sort of a wishy-washy, optimal middle ground. But that's how much sleep do you get on average? It doesn't mean 1 or 2 bad nights a week is a problem. It doesn't mean that, if you're wearing a sleep tracker, well, the sleep tracker said I only got 6, but it felt like 7 to me. Which one should I believe? Well, they're both correct to a different degree, but the recommendations are all based on what did you perceive? What did you feel? So if I felt like I got 7, but my watch says I got 6, you're in the 7 box in terms of risks. And people should know that. So yeah, I mean, what about 6? Well, if you're getting 6, the likelihood that 6 is enough to get you everything your body needs is a little lower. For some people, they're probably fine at 6. For some people, they think they're fine, but they're not. That's the other thing, where when you sleep deprive people in the laboratory, after a few days, they think they're adjusting, but actually they're not. If you look at their body, they're not, but they think they are. So asking people, do you think you've adjusted to 5 or 6 hours? And they say yes. I don't actually care what they say in terms of the truth, because people have no idea. So at 5 or 6, the lower you get, 5, it's very unlikely that's enough for optimal function. Is it enough to not get a heart attack? Maybe, but is it enough to keep you to have you the energy and the focus and the other things during the day? It's probably not quite enough for that. But that's what it depends on, because everyone's a little different. But on average, probably more than half of the people out there, they probably need at least 7. As you get older, you might be a little more resilient with a little bit less. But the further you're drifting away from 7, the more you're rolling the dice.
So can you make it up with naps? The person that says, "Well, I'm getting 5 or 6, but I take a nap during the day."
Yes, you can. Naps. So you're going to see if you do a Google search on health and naps, you're going to see a really confusing landscape. Some studies are going to say naps are good. Some studies are going to say naps are bad. And this is why. I'll explain why. Naps themselves are not the problem. Think of a nap like a snack. A snack in the middle of the day, a light snack that's healthy, that's not huge and super calorie dense, but maybe some protein, some fiber in the middle of the day. Great way to boost your energy, boost your focus, decrease overeating later because you're not going to be as hungry, et cetera, et cetera, et cetera. So are snacks good? Well, lots of people who are snacking during the day are not. They're eating bags of chips and cookies and stuff. That's not, that might help you focus and have energy, but that might count against you diet-wise. And if you find yourself snacking because you want to help increase your focus, that's one thing. But if you find yourself snacking because you're so hungry you can't make it to dinner time, that's an issue. That's not a problem with snacking. That's a problem with your appetite and your hunger. And if you're snacking all day, if you're eating and not even aware of it, if you're grazing all day because you're hungry all the time, that's a, that suggests there's a problem. You probably shouldn't be doing that. So a nap itself is sleep. It counts. It can actually, sometimes a daytime nap, a brief daytime nap, can do wonders for focus, performance, across the board, learning, memory. But if you find yourself unable to maintain wakefulness, you're passing out, you're nodding off when you're trying to stay awake, that's a sign. It's like you find yourself eating even if you're not hungry, even if you want to not be eating. So I would look at napping behavior as are you in control or is the sleep in control? And if you're not able to control it, it suggests you've got an issue that might need fixing. But if you choose to take a nap, if you're like, look, I'm 70, I wake up at 4:30 in the morning now, and then I'm too wide awake and I can't get back to sleep, and I've done everything I need to do. It's like, okay, we'll start your day at 4:30, but take a late morning, early afternoon nap, do an epilogue. Have a sleep epilogue, and it counts as part of the story.
All right, so we're going to take a quick break, I promise. When we come back, lots more to talk about: insomnia, medications. You take meds, no meds, apnea. So we just going to recognize our sponsor here. So do you know anyone who may be concerned about an older driver? Well, Senior Care Authority's Beyond Driving with Dignity program is a facilitated self-assessment program for older drivers. This program has been designed to serve as a vital tool to facilitate older drivers and their families as they make the appropriate decisions regarding the future of one's safe driving career. If the individual is a safe driver, an advisor will provide him or her with strategies on how to remain a safe driver as they progress through the aging process. If driving retirement is the appropriate decision, then the individual and their family are offered possible alternatives, resources, and a specific plan to ensure a smooth and successful transition from the driver's seat to the passenger seat. So to learn more, go to www.beyonddrivingwithdignity.com or call 877-907-8841 to connect with a Senior Care Authority advisor in your area. We're back with Dr. Michael Grandner, who's the director of the Sleep and Health Research Program at the University of Arizona. And we're talking about sleep or lack of sleep. So Dr. Grandner, talk to us about medications. All right. I mean, I'm just going to, bring up that, I'm in kind of that age group where everybody's complaining about how they can't sleep and they have to take meds and all of that. I don't want to get you in trouble with your fellow doctors that are listening to this podcast.
Let me tell you the truth, and everything that every sleep doc knows that a lot of patients don't know. And actually, first of all, I want to say that a lot of patients are getting their sleep-related medications from non-sleep specialists who are not really trained in sleep stuff.
Right,
so
exactly.
People prescribe all the time, all kinds of stuff that is not recommended for sleep. And then they wonder why it doesn't work. So let me backtrack for a second and talk about what is insomnia. Insomnia has an official definition in the International Classification of Sleep Disorders. That is the official document of what is insomnia. And the official definition of insomnia is a persistent difficulty either falling asleep at the beginning of the night or being unable to resume sleep in the middle of the night or waking up too early and not being able to get back to sleep. So your insomnia could be in the beginning of the night, middle of the night, or end of the night. Doesn't matter. As long as you're trying to sleep, but you can't. The rule, there's no official cutoff, but the general rule of thumb is about 30 minutes. So if you're trying, not like laying there reading a book, but if you're like trying to fall asleep and it's taking more than a half an hour at a time, that's a good sign that you might have insomnia. The other criteria are, it has to be at least 3 nights a week. So if you have a crappy night of sleep 1 or 2 days a week, actually that's normal range. That's within normal limits, especially as people get older. That's not terribly unusual. And it doesn't really, it's not really associated with anything bad. It also has to have occurred for at least 3 months for it to meet criteria for that insomnia disorder. If it's under 3 months, it could be acute. About 4% of the population will develop an insomnia in any given month. That's 1 out of 25 people. But 90% of the time it goes away on its own within a few weeks, so don't worry about it. But if it persists, then you get to diagnosis, and it's got to cause some sort of daytime impairment. That's insomnia. So at least 30 minutes, at least 3 nights a week. And so once you meet criteria for insomnia, so amount of sleep actually is not really relevant to the diagnosis. You can have insomnia and get 8 hours. It just takes you 10 hours to get there, for example. So if you look at insomnia, if you look at every guideline for the treatment of insomnia that's published by every organization that's published a guideline based on the scientific literature, they all say the same thing about what the recommended first-line treatment of insomnia is. This is a treatment that's actually been around since the 1980s. It's extremely well studied. It has been shown to work better than any other treatment on the market, at least as good or better in the same time frame, but it has fewer side effects than anything else on the market. It works in people who have insomnia who also have sleep apnea. It also works in pain, also works in COPD, substance abuse, depression, PTSD, pretty much cancer, pretty much any other medical issue that could be seen to potentially cause the insomnia or be resulting from it. It doesn't need to be simple insomnia, it could be complicated. It's been studied dozens of hundreds of times. It is the most recommended treatment for insomnia. The problem is most people aren't getting it. And it's called cognitive behavior therapy for insomnia. It is a manualized protocol for retraining your own body to sleep using its natural ability to sleep. It works not 100% of the time, about between 80 and 90% of the time, it'll work if done properly. The only problem is you need to find someone who knows how to do it. It's not part of the standard training in medical schools or even clinical psychology programs or social work programs. So you need to find someone who's trained to do it.
What is that called again?
It's called cognitive behavior therapy for insomnia. And some people who've been to to a psychologist, they've gotten something like cognitive behavior therapy for like depression or anxiety. This is very, very different. CBT for insomnia has very specific components that are all about retraining your brain and your body, your own biology to sleep the way it's meant to, using your body's own natural sleep drive and circadian rhythms. There's a whole set of techniques involved. It's very data-driven. It works really well. If you want to find somebody who can do it, there's a couple of really good directories out there. One is behavioralsleep.org. That is the website for the Society of Behavioral Sleep Medicine. That's our professional organization. So there is a directory for potential patients where you can see where members are around the country and around the world. You can also, there's another website just called cbti.directory. It's hosted by the University of Pennsylvania, they're the biggest trainers in this. And so everyone who's been through any of their training or is affiliated with anyone who's been through one of their trainings is in their directory. And you're talking about, hundreds of people around the world. If you're in a state and in a U.S. state and you don't see someone in your town, I should let you know that most psychologists, especially since the pandemic, some of the laws have changed, and you can do telehealth with somebody as long as they're in your state. Even if they're on the other side of the state, you can usually do telehealth. So I see people up in northern Arizona, for example. And some people can even see people in other states if they can be licensed in the other states. So don't be discouraged if you don't see someone in your town. And I just want to stress this because CBTI is the first line treatment for insomnia. It has outperformed every prescription medication that's ever been on the market, including the older, more sedating ones that are just more dangerous, and so we don't use them anymore. It outperforms those, at least it works as well or better. For example, about 20 years ago, there was a big study where they pooled together all the research on all the older sleep medication, like the temazepam and the benzodiazepines. This is when Ambien was first coming out. So all the newer ones weren't even out yet. Compared to CBTI, in the same treatment period, they were equivalent, except CBTI helped people fall asleep faster.
So
other than that,
Yeah, so a couple questions.
Yeah.
One, I'll do it one at a time here.
Yeah.
One is somebody who starts CBTI with somebody
Yeah.
like yourself, a specialist. Usually, how long does that take? How long does that process
The
take?
typical patient is 6 to 8 sessions.
6 to 8 sessions, and you're
That's
meeting
it.
with them weekly, or
Usually, me, I don't have like because I'm mostly in the lab. I don't have as an opportunity to see people weekly, but most people do weekly, either every week or every other week.
okay,
6 to 8 sessions is pretty average.
that's great. Question number two. Again, I don't want to get you in trouble with your
It's
doctor
fine.
friends. All right.
I
So this, you are so sure about this, which it's been written, it's proven 80 to 90% effective rate.
yeah.
Why are doctors giving out these medications instead
Honestly,
of referring them to people like you?
that's a great question. We've been tackling this in the field. I mean, honestly, it took us a generation to get enough. It's very unusual that a non-medication treatment outperforms medication. It's actually very unusual that that occurs. And like in depression, they're about equal. With insomnia, the non-medication approach is better. But it's taken us literally a generation to get the data to the point where everyone is on board with, okay, we get it. So now the question is dissemination. It's not part of the standard training because what is in standard training, this was decided like 20 years ago, and it's actually not that hard. And that's the other thing I'll tell you. And for anyone who's listening out there who's like listening to this, they're also a therapist, they're also a social worker or whatever, it's not that hard. There's manuals out there. You can train yourself on how to do it, offer it to your patients. There's training programs so you can get board certified in it, but it's really not that hard to do if you know what you're doing. No, there's not big money behind it. There's no one selling it.
That's
So,
the thing too.
and also it's much easier to write a prescription. Like especially if you're primary care or psychiatry or whatever, it's much easier to say, here, I know this will probably help you. It's not much effort on my part. You're probably not going to complain about it. This other thing requires work and effort. And also, until recently, this is another big issue with health insurance, where it's usually provided under a behavioral health benefit. And a lot of people had trouble getting that covered by their insurance, where insurance will pay for a pill, but they won't pay for this, even though it works better. So nowadays, I haven't had trouble getting insurance to cover it. Because any insurance that covers any kind of psychotherapy will cover this, because it bills on paper, it bills the same as psychotherapy.
So they could go to behavioralsleep.org if they're outside of Arizona. If they're in Arizona, they could look you up, right?
They could look me up.
Grandner.
Or anyone else. I mean, I'm like I said, I'm here to tell the truth. I'm not the only one who does this. There's actually more people out there now than there were 5 years ago, and that was probably double than what it was 15 years ago. It's growing. It's just growing organically and slowly for that reason. There's not a whole lot of, but it's okay. CBTI. But in terms of medications can work as well. I would suggest that if people want to know the truth about medications for sleep, there's a great, I'm warning, this is an academic paper. So there was a paper that was published by the American Academy of Sleep Medicine. So the American Academy of Sleep Medicine is the main organization for sleep doctors, like MDs, physicians. They're the main organization for sleep physicians. Most of what sleep physicians do is more sleep apnea, but they do all the other stuff too, including any kind of prescription sleep medication is sort of their domain. They put a paper out a few years ago where they did a comprehensive survey of the published literature on sleep medications. And they have practice parameters for sleep doctors of, here's what, if we actually looked at the published data, here's what we recommend. And I can send you a link to that and you can post it where people can read the direct source. It's pretty, I think it's freely available. If not, the summary is freely available where they go through medication by medication. What does the data say it's for? The most prescribed medication in the US is Zolpidem or Ambien. It does have documented effectiveness, but it also has side effects, especially for older people. It does have of the ones that are out there, it seems to be relatively safe and effective, but the main side effects for it tend to be things that older people want to avoid, like daytime grogginess, inability to focus, problems with reaction time, fall risk. It dramatically increases fall risk,
Yeah,
and memory problems. And
I
so,
know of a lot of people who had challenges with that drug, but that's a whole nother
yeah,
thing.
I mean, and that's sort of the issue where it's like, well, is it helping more than it's hurting? Like, are you having cognitive problems during the day because you're not sleeping? Now I got you to sleep, but now the main side effects of the thing
So
that
if you had somebody go through this program, you said 80-90% effectiveness. So that 15% or so that it wasn't effective,
yeah,
would there be a medication that you'd recommend,
yeah.
or
I
that's
mean,
a tough
well,
thing?
it depends on the person. Um, so zolpidem is among a class of drugs alongside zopiclone or esopiclone, which is Lunesta, um, and Sonata, which is Zaloplan. They work similarly. It's similar to they're sedating. They work through sedating. Um, there's a different newer class of drugs called DORAs, or dual orexin receptor antagonists. This is suvorexant, which is Belsomra. There's lemborexant, which is Dayvigo, and there's daridorexant, which is Quviviq, which there's commercials out. It's the newest one, so people may have seen commercials for it. They work very differently. It's not sedating, which is why that tends to be more recommended for older adults. It's not sedating, doesn't cause memory issues, doesn't cause fall risk, it seems. They have different side effects. They work instead of by increasing the sedating neurotransmitter, which is where all the side effects come from, because if you're pulling yourself down, you're pulling other things down too. What this one does is it works by not increasing sleep drive, but by sort of reducing wake drive, because those are different things. And so it sort of opens the door to sleep instead of dragging you through. So it doesn't work in the same way, but it does. They do tend to be safer for older adults.
Right.
But I mean, as a psychologist, I'm not the one prescribing the medication, so of course I got to defer to the physicians. But those are the ones that are more recommended. You have things like one of the most commonly used sleep medications is trazodone. Trazodone is not a sleep medication. It's an antidepressant. It was developed as it's in the same class of antidepressants as like Prozac. It's similar in that way. It just has a sedating side effect because it hits on histamine like Benadryl does. Mm-hmm. And so, but because of its antidepressant effects, if you look at the data, the reason why trazodone is not recommended for insomnia is because it doesn't do anything to sleep-wake rhythm regulation. It doesn't help you fall asleep any faster. It doesn't increase your amount of sleep time at all. It doesn't reduce the amount of time you spend awake at night. It doesn't make you feel more refreshed in the morning. However, what it does do is it feels like it's working. If people who take it feel more calm and relaxed, and when they have a lot of anxiety around sleep, it reduces some of that anxiety. And if that was the barrier, patients say that they like it. But that's why sleep doctors tend not to recommend it, because it doesn't actually do anything to sleep, and versus it doesn't beat out placebo. However, on a one-to-one, on an individual basis, patients tend to say that it does the trick for them, especially for people whose insomnia is more mild, where it's not that if they don't need to increase their sleep during the night, they just need to feel less stressed about it. Increasingly, people are given antipsychotics in low doses for insomnia. That's very troubling because there's no data to support that. And if anything, that's riskier, but people starting to do that, that's troubling. Or also, antihistamines like Benadryl and others, you can get it over the counter. It's sedating, but they have longer half-lives and you feel more impaired the next day. There are also other sedating antidepressants like mirtazapine. People are given all kinds of stuff that's not really recommended.
Isn't it true? I mean, I have talked to other specialists in this area that the over-the-counter, like you mentioned, the Benadryl, there's been studies showing that could lead to some form of dementia.
They're not made for long-term use. They're a Band-Aid. It's like, they're perfectly acceptable for there's a night or two that you've got, there's some pain, you're sick or something, you just need something to carry you through the night. You don't really care that it's going to impair your functioning the next day. Fine. But for long-term use, it dulls your ability to do all kinds of things. It's like if you can't focus, you can't take in information. If you can't take in information, you can't process information. If you can't process it, you can't retrieve it. So what happens is people develop these sort of memory issues because they're just walking around with fuzzy glasses on all the time, and they just sort of adapt to it, but they're not at peak functioning.
Right. So Dr. Grandner, I wanted to talk to you about sleep apnea, but unfortunately we're just out of time. I'd love to have you back though at some point.
Of course,
in the
we could
future.
do a whole thing on sleep apnea.
We'll talk about sleep apnea. That's a real important subject. This has been extremely enlightening, very educational, and I really appreciate you joining us on Boomers Today. Really do. Yeah, thank you so much, and thank you everybody for joining us on Boomers Today. Please stay safe out there, and we'll talk to everybody next week.
You've been listening to Boomers Today with Frank Sampson. To learn more about today's show, visit boomerstodayradio.com and join us next time for another edition of Boomers Today.